And maybe while we're on that, maybe we can talk about how this actually attacks you because it goes into the respiratory tracts and it ends up in pneumonia, which ends up in lungs not functioning and death. Is that right?
Yeah. So what happens is the virus goes into the lower respiratory tract, and it'll cause, in the cells of the lower respiratory tract, it will get into those cells. And the reason it gets into those cells is that is the only place in the whole wide world that I know of that the virus can reproduce. So the virus can only reproduce in specific human cells that have this ACE2 receptor on their surface. Now, there probably are other cells with ACE2 receptors within the body, but of course, the virus isn't going to access those initially because you breathe it into your lungs. So the virus gets into these cells in the lower respiratory tract. In those cells, it multiplies. Now, viruses are absolute scallywags. What they do is they hijack the cell's own genetic apparatus that the cell normally uses to synthesize its own proteins and forces the cell to produce new viral proteins. These are then constructed into new viral particles with new RNA in them, and these then bud from the surface of the infected cell, probably thousands of them from an infected cell. And because these cells are lining the respiratory passages, these viruses go into the respiratory passages, into the mucus. Then, of course, you breathe, you cough, you sneeze, and they come from the mucus out into the air, and we get this droplet infection effect. And that can go directly from person to person, which is why we want 2 meters distance. Or it can, if I'm an infected person, for example, and I cough onto a surface, you then touch that surface, the virus goes onto your hands, then the virus can go into your mucous membranes in your mouth, your nose, or your eyes and infect you that way, because from your eyes, your mouth, or your nose, it will go down into it can go down into the respiratory tract from there. Now, once it's in there, what happens is the viruses in the cells actually change the biochemistry of the cell, and viral proteins are shed or excreted, if you like, onto the surface of the infected cell. Now, as a result of that, the specialized immune cells called T killer cells, or NK, natural killer cells, they've got a great name. They're just natural killers. And these kill the infected cells. But of course, when they're killing the infected cells, they're causing quite a lot of inflammation at the same time. And that causes swelling in the airways. But it's quite a clever strategy because it kills a lot of the viruses. So the analogy I used to use with my students is it's like throwing a hand grenade into a room full of terrorists. You take out the room, but you take out all the terrorists in the room as well. So these natural killer cells, by killing the virally infected respiratory lining, the respiratory epithelial cell, kill a whole load of viruses, but then they leave inflammation. And that inflammation causes swelling. So the airways can swell. And if the airways swell, they kind of squeeze in the way. So that means you've got less space through which the air can go. So people can feel quite short of breath. And often people do feel short of breath with this illness, but that doesn't necessarily mean they're going to develop severe complications. So the severe complications, the people that become critical, what happens is the virus actually gets down into the very bottom of the air sacs, the alveoli, these microscopic air sacs where the oxygen gets in and the carbon dioxide gets out. And they cause inflammation in there. And that inflammation causes the production of fluid which seeps into the alveoli. So instead of having an air sac which is hollow and full of nice fresh air that you've just breathed in, it's full of inflammatory fluids. And that's called ARDS, acute respiratory distress syndrome. So a lot of these patients that are critical get acute respiratory distress syndrome. That's the inflammatory effect of the virus. But as well as that, when these cells that line the respiratory epithelium are damaged, basically, instead of having a nice smooth layer of mucus with a nice smooth layer of columnar ciliated epithelial cells lining your airway, what you've got is big holes. It's like someone's taken a few teeth out and you've got big gaps. And bacteria get into those gaps. And you can get bacterial secondary infection, and that can lead to bacterial pneumonia as well, where again the alveoli fill up with fluids. So if we take a pandemic like the 1918-1919 pandemic, there's been some fascinating studies there. That was an influenza A. It was an influenza virus. It wasn't a coronavirus. But recently, there's some fascinating videos on YouTube about this, where people have gone up to the permafrost, for example, and exhumed bodies of people that died from that condition in 1918, 1919. And they've analysed the virus, and they've found the genetics of this H1N1 influenza virus in those people, confirming that diagnosis. But they've also found that quite a few of them did develop secondary bacterial pneumonia as well. Now, we can't kill the virus at the moment any more than we could in 1918. But of course, we can kill the bacterial secondary infection. And that's where the supportive treatment becomes so important as we monitor these patients, make sure the blood oxygenations are adequate, monitor their chest x-rays, see how much of the lungs are filling up with fluid, and treat them accordingly.